It's my pleasure opening this panel discussion titled Optimizing Colorectal Cancer Screening Insights After COVID-19. So, as you know, colorectal cancer is the second leading cancer in incidence, and in order to reduce its morbidity and its mortality, it's pivotal the improvement of the current colorectal cancer screenings. So the main challenge that these screening programs face is to balance the cost efficacy of the programs. So, and these programs, they have in one hand the colonoscopy, which is the gold standard technique to diagnose colorectal cancer, but it's invasive with a high cost and associated risk. And on the other hand, there's the fecal immunochemical test, which is used in the majority of the colorectal cancer screening programs to select the people to undergo the colonoscopy. But its high false positive rate and the low positive predictive value still leads to a 30% of the necessary colonoscopies. So the backlog caused by the COVID-19 pandemic has amplified this already existing need of the colorectal screening programs. So today we have two top speakers that will share their experience during the pandemic, and we will discuss and contrast which should be the new approach after the pandemic. So in one side, we have Dr. Josep Alfonso Espinàs, who is coordinator of the cancer screening programs of Catalonia. He's a medical doctor and PhD, specialist in preventive medicine and public health. Since 1995, he has been working on oncology director plan of Department of Health Catalonia, is responsible of the coordination and the implementation, provision, evaluation of the programs of the cancer screening in Catalonia, and he also has participated in different impact and in different research projects related to cancer screening. So today he will explain the impact of stopping the screening program during the backlog and which strategy they decided to apply during the COVID-19 pandemic for the Catalan colorectal cancer screening program. So welcome. And on the other side, we have Dr. Francesc Balaguer, head of gastroenterology department at Hospital Clínic of Barcelona since 2016, and director of high-risk colorectal cancer clinic since 2006. He's gastroenterology with a PhD and a postdoc at Baylor University Medical Center. He is part of the research committee of the United European Gastroenterology Society and collaborative group of the Americas and Gastrointestinal Cancer. His research is focused on clinical and translational understanding of high-risk colorectal cancer conditions. And so today he will explain how they are managing the waiting list of the colorectal cancer symptomatic patients during the pandemic. So we first will go to the presentations, and after this, then we will have the questions and the discussions. So we will start with Dr. Josep Alfonso Espinàs. Thank you.
Good morning. Thank you, Mariona, for your presentation. And first of all, I would like to thank the organizers for the invitation to participate in this meeting. In my presentation, as Mariona has said, I will talk. I'll begin with some data, short presentation of the Catalonian Health Service and the Catalan Cancer Screening Program. After that, I will explain and show the COVID impact, the pandemic in the colorectal cancer screening, and the restart, the decisions and consequences of these decisions, the early impact of these decisions on our screening program, and finally some final remarks. In this map, you can see where Catalonia is situated. It's in the northeast of Spain. It's where we are now, just at this moment. Catalonia has more than 7 million inhabitants, has a national health service type healthcare system. that's to say that every citizen has a right to the public healthcare system in Catalonia. And the Catalan Department of Health and the Catalan Health Service, the CatSalut, is responsible for organizing and providing the healthcare services at regional level. It's a decentralized healthcare system, the Spanish one. Our colorectal cancer screening program is a population-based organized program. It's a single program, but it's decentralized, managed, and we have 11 screening offices that manage the program in their own areas. Our target population is almost 2 million people, men and women, 50 to 69 years old. Our screening test is a faecal immunochemical test, and these are the regular cutoffs of the test for a positive for indication of colonoscopy before the pandemic. The screening interval is biannual, and participation is by individual invitation letter. In that letter, we ask the participant to pick up and return the collector, the feed kit collector, at primary healthcare centers in one part of Catalonia, the west part of Catalonia, two regions, and at the community pharmacy on the rest of Catalonia. If the feed is positive, we recommend a colonoscopy with sedation. We have 43 endoscopic services performing the colonoscopies that the program generates. In 2019, we reached 100% coverage by invitation. In fact, it was a bit earlier, but there were some small area in Catalonia that was not covered until 2019. But now, from that time, we have 100% invitation coverage. I will show some results of the program. The text is in Catalan, but I think I will explain, and it will be easy to understand. Here we have the different years of the program, and this data show our participation rate. As you can see, our participation rate in the last year we have a complete assessment. It was 44.6%. It has been along these years under 50%. And that, as we'll show you later, it's one of the challenges we do have. No, we haven't reached even the 50% of participation. You can see that here are the number of invited participants, and when we make the biggest increase in invitation, almost doubling, our participation went down, probably due to the organization factors at the beginning of the screening program in some areas. Here you can see our feed positivity, colonoscopies and detections. The feed positivity was 5.11% in 2019, and you can see that the positivity rate has been going down, and this is due to the bigger number of subsequent screens in the population. He predominantly were first-time screeners, where the positive rate is higher, and now we are in a more stable situation. You can see the number of colonoscopies that were generated by the screening reach a peak of 21,000 in this year, in 2017, and now it's a bit lower than 20,000 positives and colonoscopies. In that part of the table, you can see the detection rate of the lesions. If we begin with, we show you the invasive cancer detection rate. In this year, we detect 335 invasive cancers. This is the rate per mil per 1,000 participants. We also detected 6,000, more than 6,000 people with adenomas, with advanced adenomas and intermediate risk adenomas. That is what will produce the preventive effect of colorectal cancer. We detect almost 4,000 people with low-risk adenomas and 6,700 colonoscopies where we did not find any neoplastic relations. What that was, we can consider that the false positive, clearly the false positive. We can discuss if these are also false positive, but clearly that this number is the false positive of our program. If you see these numbers from the positive predictive value, that's to say the percentage of lesions detected at a colonoscopy, we can see that in 3.5 of the cases of the colonoscopies performed, we detect an invasive cancer. In 37%, we detect a high-risk adenoma, and globally, in 45%, we detect a significant lesion. It was a cancer or a advanced adenoma. And in this figure, you can see the distribution, the stage distribution of the cancers, the invasive cancers detected, and you can see that it's similar in different years. Almost 70% of the invasive cancers detected are stage 1 or stage 2 cancer, which is a quite favorable stage distribution. It's almost the opposite of the previous symptomatic stage distribution, that 70% are detected in higher, in more advanced stages. With the numbers, I would like to point two challenges, two main challenges. One is to increase the participation. Our participation is below the standards that we would like to achieve, and that is one of the main challenges we do have. And the other is that it's somehow related to the previous one, the limited colonoscopy availability in Catalonia. And there are some conjunctural factors and some structural factors. Some conjunctural factors, during this period, we live in accelerated extension phase of the program. Most of the screens were first-time screens where the positive rate is higher, and that generates a higher demand of colonoscopies. And Also, a reorganization of the hospitals, a need of healthcare endoscopies professionals to perform that colonoscopies. The peak of the prevalent screenings was, as I mentioned, reached, it was at 21,000 colonoscopies that year. After that peak reached in that year, we saw a subsequent improvement, but some structural problems remain. There are some areas where we do have some problems to offer all the colonoscopies needed for the demand we do have. Most of these problems are related to the human resources. Human resources is not a question of money, an economical question of money or equipment, but it's the problem of human resources, as in other parts, in other issues in other parts of the healthcare system. And linked to the limited colonoscope availability, I would like to mention that the impact of the increased participation would, of course, have the consequences that the demand, the need of colonoscopies will increase. So any increase in participation rate will result in a higher number of colonoscopies needed. And that was the pre-pandemic situation, and here we can see I will show now the early impact of the COVID pandemic and the start decision we took. Here you can see in that figure the number, the number of colonoscopies during 2020, these years, and 2021, the first month from January to May of 2021, compared to the to the 2019 month, the pre-pandemic situation. As you can see, in March, the pandemic obliged us to suspend all the fit invitations. And this situation lasted for some more, from March to June. We also have to suspend the colonoscopies performed to study fit positive, and also the diagnostic colonoscopies, and I'm sure that Dr. Balaguer will explain about that later. In that situation, we do have an advisory screening board, and this board meet several times to advise our health department on what were the options and the decisions to take during this pandemic and during this pandemic. Oops. The context and how to restart. What were the better ways to restart the pandemic? The context of these decisions are that, as I mentioned, we do have a limited colonoscopy availability. To make the things worse, we need more times to perform a colonoscopy due to the security measures needed to protect against COVID infection during the healthcare service. We do have a backlog of diagnostic colonoscopies. And there were uncertainty on the COVID pandemic evolution. At that time, we are talking about this month, we didn't know what will happen in the future about the pandemic, how will be the evolution of the pandemic. Also happened that at that time, we do not have any evidence on the different impact on the different possible restart options. After that month, we have some data pointing out which options are better than others, or which advantages have some options than the others. But at that time, we don't have yet this information. And to restart the program, the screening invitations, the program means two things: that we need to restart their normal activity, performing as many colonoscopies as before, but we plus the catch-up of the colonoscopy, of the screening of this backlog of screening invitations not sent. So we need to tackle this both, the normal activity and to catch up this screening suspended. The advisory board recommended as a first priority to perform the colonoscopies for FIT positive, and that was, of course, the first priority, to perform all the colonoscopies that was suspended for a FIT positive. And we applied a FIT value priorization. We give priority to the people with a higher FIT value because it's associated with a higher risk of a significant colorectal lesion. But the third decision was what to do. To raise the cutoff point of our program, to reduce the number of colonoscopies needed in this context, due to this context, or to maintain the cutoff, regular cutoff, that in our case, due to all these context elements, would mean that every month from the restart, every month after the restart, the delay would increase sometime, because our capacity was not enough to do all the colonoscopies needed because of this situation. And the advisory board recommended to raise the FIT cutoff point. And to do that, we estimate the impact of this modification on colonoscopies, detection lesions, and positive predict value of the indication for colonoscopy, based on the 2018 data year, and this year, that was the previous year, we have the evaluation of the program. At that cutoff, we needed this number of colonoscopies. We detected this number of colorectal cancers, invasive cancers, high adenomous lesions, and the predictive positive value of the indication of colonoscopy. That were the numbers of the pre-situation COVID. And here you can see in that figures the estimated consequences of reducing the need of colonoscopies by using highest cutoff values. And finally, we decided, for the reasons mentioned and the situation of the endoscopic units that were assessed, we decided to choose a cutoff of 1.55, which will result in a decrease on 20% of the colonoscopies, but the price we pay for this reduction was that we will reduce the detection of 10% reduction in the invasive cancer detection in this round, and a 20% reduction of adenomas, high-risk adenomas detection. On the other hand, this option, what makes is that it allows the program to focus on the higher risk population, because the positive predictive value for cancer increase it from 3.6 to 4.3 for every colonoscopy performed. We detect more cancers and more adenomas than in the previous situation. And the reasons for one of the decisions, the basis for that modification of the cutoff point, here I just mentioned four of them. First of all, it is clear that any cutoff value misses some cancers or adenomas. The 100 nanograms per milliliter in our test, it did not detect all the lesions, all the cancers and adenomas. So any cutoff value misses some cancers. We wanted common decision for the whole program and for the whole population, and we want to avoid a progressive increase in the delay, in the invitation delay. That will result if we do not have enough capacity to perform our normal activity pre-COVID and catch up the COVID, the activity, the screenings not done. It was a way to easily and quickly adjust the demand to the availability, and as I mentioned, it was somehow a risk-based decision, because we focus on those in those population on our screening program with higher risk of having a lesion, a colorectal lesion, because it increases the positivity rate. Now I will show you some early impact assessment of our decisions. I will show you the partial, preliminary and partial results on the invitations and on fit positivity. I am sorry, but we don't have the assessment of the cancer detection rates and the adenoma detection rates until the next month, at the end of this month, November. Here you see that was the time that we decided to increase the cutoff, and here in the 15th of September was when the authorities and the program decided to restart the screening invitations. And as you can see, in September, that's the zero situation is the previous pre-pandemic situation, and that's the percentage of invitations, minus invitations or more invitations than in the pre-pandemic situation. As you see, that was the reduced participation, and from that time, what we have achieved is that we are inviting with some variation due to the subsequent pandemic wages. We are inviting more population, more people into the program due to that before the pandemic. That's because we can invite more people, because the generation of positives and colonoscopies, the demand of colonoscopies decreases because of the new cutoff. And what happens with the positive rate, fit positive rate? If you see this last part of this table, we predicted a 25% reduction of positive rates and colonoscopies. And the first month of the 2021, we had a reduction of 27% of positive rate or colonoscopies, more or less what was expected. That means that during this month, if we had maintained the regular cutoff, we will have need 30, almost 14. It's just some month. 14 colonoscopies performed, and with that reduction, increase in the positive rate, in the positive cutoff, we do have need 10,000 colonoscopies. And some final remarks. That decision has allowed us to screen, to restart the screening program, and to restart the screening program in the conditions we have considered optimal, in taking into account all the limitations. A common decision for the whole program at some equity, meaning that not the people with all people invited from the restart of the program would have the same screening performance. It would not happen that as months pass, as time pass, the delay in invitations increased because our capacity was not enough to do the colonoscopies. And not only we have restarted the screening program, but we are progressively catching up the screens backlog, and you see these activities, what not done, are being done during these months, and until now. The next steps. The next steps, we will do the final assessment of this decision, final decision on the impact on the increased fetal cutoff points on the detection rates. And we reassess the cutoff, taking into account the impact of this decision in the detection rates of cancers and adenomas, the availability of colonoscopies in our system, and the evidence we do have now on the different optimal strategies and the different impact of different strategies to restart the programs. And some of this evidence is shown here. What now tells the studies that have the modelization studies that have analyzed what are the consequences of different strategies, and some of the results are so obvious and probably is not needed to do any mathematical modeling. The assumptions for to minimize the colonoscopy, the COVID impact, depend largely on the colonoscopic capacity. It's clear, it's obvious, and some of the minimization strategies are restart as soon as possible, catch up the activity not done as soon as possible, maintain the participation rate. That has been one of the problems we have found in some programs, not in our program, that the people are more reluctant to participate in screening due to the possibility of COVID transmission or COVID infection. One of the things we do know now, and we were applying in our program, is that do not lose the last screening rounds for those people that, due to the delays in our invitation, exceed the upper age limit. Those people that should have been invited at 69, some of them, because of the late, the invitation was sent when they were 70 years old, not 69. But in theory, that it is not the age range of the program, but it's important to not to lose this last screening round. That is one situation that it's easy applied and have the most impact on the minimization of the minimization of the impact of COVID. And the other point there are discussions about is the decision we took at that time in July, that raise the cutoff threshold or lengthen the rounds of the screening situation, of the screening invitations. There are additional factors that will help to minimize the impact of the COVID in the program, and that more than that are important for improving the colorectal screening, even with COVID or not COVID, than are optimize the use of colonoscopy resources at short, medium, or long term. The FIT program has a FIT screening program. The positive thing of that test is that it's easy performance and quickly performant. It's has no limitation. It's a laboratory test. It has no limitation, main limitation on human resource needed. But the consequences of a positive test, the colonoscopy, is the bottleneck fact of our program. So we will have to optimize the use of colonoscopy resources. Moreover, there is an invasive procedure with some low but risk of complications, and that would mean to optimize the use in the FIT positive. What is the optimal cutoff point in the programs? Just I want to remind that the Dutch program in the Netherlands, the cutoff point is 47 micrograms per gram feces, which is more than the double of our regular pre-pandemic cutoff. Their regular cutoff was much higher than ours, and the same happens in the UK or the Swedish, where the cutoff of the screening program is much higher than our previous and our pandemic cutoff decision. So that it's a decision that has to be taken. The other point that will help us to improve our screening programs in general and in this post-pandemic period particularly is the protocol of to follow up the screen detected adenomas that generates a snowball of colonoscopies in the near future. And the European Gastroenteroscopic Society has recently, some time ago, issued a new recommendation that in principle reduces the number of colonoscopies and the people, the number of colonoscopies needed for follow-up of this adenoma detected. To apply risk-based strategies, the FIT positive cutoff is in some sense a risk-based strategy, deciding higher or lower. We can discuss if we need to apply different cutoffs for women or for men, as the Swedish, in Sweden they have done. That's one point. And obviously better screening tests. That's an important point. FIT, it's a good screening test, but it has limitations, a number of false positive rate of positives that it will be nice to reduce if it's possible. And here, more to medium, long, or short terms, we could think on or work on better screening tests. Thank you very much.
Thank you. It has been so interesting, and we already have a lot of questions, but we will take them after the presentation of Dr. Balaguer. Just remember that you can introduce more questions through the application, and then after this presentation we will take it. So.
Well, good morning everyone, and thanks Mariona for the invitation and organizers of the meeting. It's a pleasure to share with you how are we facing the prioritization of colorectal cancer detection in the post-COVID era. This has been covered by Dr. Espinas, but we have to just remind that this is a very frequent cancer, this is a very incident cancer, and still a lot of deaths occur in Europe and all around the world due to this tumor. And this a tumor in which we know pretty well the natural history, and we know that we have a very long window of opportunity to detect it before it gives rise to symptoms, and this is where the screening programs make sense. But then when the tumor develops, then patient develops symptoms, okay, and then we're going to focus on this part. The screening part, it's been a history of success. So if you screen a population with a FIT test, and these are results from our country, after a few years you start seeing a decrease in the mortality due to this cancer. But however, this not reach everybody in the population, as Dr. Espinas said. So many patients still do not receive screening, and they present symptoms that are suspicious of a cancer in the colon. And colorectal cancer, when develops, usually the most frequent symptoms are rectal bleeding, change in bowel habits, usually constipation or diarrhea, iron deficiency anemia, and abdominal pain. But you have to keep in mind that these are very, very frequent symptoms in the population, and to diagnose a cancer, we will need a colonoscopy eventually, because it's the test that we need to perform to diagnose the tumor and take biopsies to make a definite diagnosis. So colonoscopy will be always the test to diagnose colorectal cancer in a patient with symptoms. However, many studies have evaluated what is the diagnostic value of symptoms to detect colorectal cancer. And if you take each symptom individually, what I show you in this slide is that the sensitivity it's very, very low. So for rectal bleeding is 17%, for abdominal pain is 35%, for diarrhea it's 20%, constipation 13%. So many patients with a cancer do not develop these symptoms. And so that makes that these symptoms by themselves are very low sensitive, but at the same time they have a very low specificity, because many patients, many of us, will have many of these symptoms without having a cancer. So this is a big limitation in terms of prioritizing the use of colonoscopy to detect colorectal cancer. In this slide, this slide summarizes actually the positive predictive value of each of these symptoms to detect the cancer. And as you can see here, the positive predictive value, usually each symptom independently, it's not bigger than 2%. So we have to perform 100 colonoscopies to detect one cancer based on these symptoms. And if you combine some of these symptoms, you can get higher positive predictive values, but not higher than 10-12%. So still we'll be doing colonoscopy in 90% of the cases without a cancer. So how can we overcome these limitations of symptoms? No? And these are the National Institute for Health and Care Excellence in the UK. And they have many of the studies that I will show you come from there, where this has been studied very in depth. And 96% out of 100 patients referred urgently for symptoms to perform an urgent colonoscopy in the UK will not have a cancer. So we are doing many colonoscopies with little success. So one of the strategies that have been proposed for many years is to use a FIT test, a fecal immunological test, before colonoscopy to try to prioritize and select those patients that will more likely have a cancer. And in the sense that if the test is positive, we will perform colonoscopy, and if negative, we could delay or maybe avoid doing the test. So how does this strategy work? As I said, there are many studies, systematic reviews, meta-analysis. Here I show you the last study published very recently in GUT with more than 20,000 individuals in the UK, analyzing with symptoms and analyzing the performance of FIT in this population. And we can see that if we, depending on the cutoff that you set, the results will differ. Using a very low cutoff, which is 2, which is almost having a positive test instead of 0, 37% of positivity in the population, sensitivity of 97%, this is very high, low specificity 64, positive predictive value 8.7. Okay, so this means that it works pretty well in terms of on detection using this low cutoff. By using a 10 micrograms per gram of feces, as you can see, the positivity rate is lower, almost 20%. Sensitivity a little bit lower, 90%, increase in specificity and positive predictive value. And the higher you go, the more specific you get and the more positive predictive value, but you are still missing some cancers. So it works pretty well in this population for prioritizing. And this is maybe an easier way to do what this is a simulation of what would happen in 1,000 individuals if you with symptoms and you give a FIT test. If you use a 10 microgram cutoff, you will get around 20% of cases positive. You will do a colonoscopy in this population and you will get 30 cancers. And 179 patients will have a negative colonoscopy, so they will not have cancer. Okay? And if in the majority of the population, 80%, the FIT will be negative, you will not do a colonoscopy. But if you did a colonoscopy, you would find a cancer in 2 patients, and in almost 800 patients, the colonoscopy will be negative. So here in the right side of the slide, you can see that by doing this strategy, you are detecting more than 94% of cancers. You are avoiding almost 80% of all the colonoscopies, but you are getting 85% of false positive cases, so you are still doing colonoscopy in patients with FIT positive that will not have a cancer, and you will have a 6% of false negative cases, so we will leave behind to some of the cancer patients. And the missed cancers, which is the big concern of this strategy, at least to me as a clinician, it will largely depend on the cutoff and on the frequency of cancer in your population. So if you have a population, in your population the cancer is around 1 or 2% of the population with symptoms, then the number of missed cancers per 1,000 patients will be around 1 or 2 if you use the 10 or 20 cutoff. Okay, 1 or 2 per 1,000. I mean, this is, if we put this in context, okay, this is almost equal to the colonoscopy risk that one patient has when you go to the colonoscopy, which you know that 1 into 1,000 or 2,000 patients get perforated and get secondary surgery, or even the risk in the asymptomatic population, which it depends on the age, can be around 1 to 3 or 4%. So we will always leave some cancers behind, but with this FIT will be very low. So this prioritization strategy has been already established in some organizations. In the NICE organization, and so many scientific societies currently recommend to use a high sensitivity FIT test for patients with symptoms. We know that the sensitivity for colorectal cancer is pretty high, but for precursor lesions is not that high, and maybe these patients could be detected through the screening programs. But as I showed you, the specificity of this strategy is not optimal, and we will be doing many unnecessary colonoscopies in patients without the cancer. So how can even improve or further the use of FIT in this symptomatic population. So one strategy would be a better test, and there are better tests available, like biomarkers in the stool, like the Colorectal, or this will at some point increase sensitivity and specificity, but I mean they are still not in the market, or they are very expensive. But another strategy is to improve the specificity, is to pair the FIT test with another test that makes the strategy more specific. And this makes a lot of sense in these days because, as has been discussed before, the COVID has changed our practice very importantly. You have to keep in mind that our endoscopy units were shut down for many months. Then we tried to catch up with all the patients that were not diagnosed during that period, and we are still facing a big burden of endoscopy that we cannot give a good response, and actually is competing with the screening program. And there are some figures of this impact. Is the reduction in colorectal cancer diagnosis during the COVID area, the increase in the diagnosis in advanced stages and mortality. Many papers have shown this all around the world. Our endoscopy capacity is not the same as before. We cannot do as many colonoscopies, so we need something to prioritize the many patients that we have in our endoscopy units and use the new technologies available. And here I'm gonna briefly show you one of the options that we have, and this is called RIDE CRC. This is a new test that has been developed based on the detection of bacterial markers in the stool. I'm not going to try to pronounce them, but these are the 4 markers that are used, that paired with the FIT test could potentially increase the specificity of the strategy by keeping the sensitivity and avoiding many colonoscopies that we are still doing. This test, RIDE test, there is a proof of concept study that was published 2 years ago that showed that in a population with colorectal cancer, advanced adenomas, non-advanced adenomas, and healthy carriers, the combination of this test performed in the stool with the FIT test gave rise to the following numbers. So these are, in this population, the results with the FIT 10 or 20 cutoff. And you can see that there is a very high sensitivity with a specificity around 70%. But when these FIT tests were paired with this bacterial test, there was a minor decrease in sensitivity, but an important increase in the specificity. You know? And this make it promising in this scenario of increasing the specificity of the strategy. There's been a validation of the results in an independent set of 325 stool samples that was published recently, and with similar results. So this column here shows the FIT 10 results for colorectal cancer detection in this population, very high sensitivity and 74% specificity. And by adding the RIDE to the test, there was a decrease of 50% in the false positive rates. So we could save 50% of the colonoscopies with as observed earlier, a slight decrease in the sensitivity. And the higher you go with the cutoff of the FIT, you get similar results of around 50% reduction in the false positive. I'm going to skip this part. So this is my final slide. So I think that with the evidence that we have now and the current situation in our endoscopy units, to use the FIT as a prioritization method in patients with symptoms should be implemented. Using FIT in the primary care at a cutoff as low as 2 microgram per gram of feces could keep the sensitivity almost 100%, and will save many colonoscopies, but still we will be doing a high number of colonoscopies that would be negative. And in this scenario, right CRC could improve the precision of the FIT strategy by lowering the number of false positives and keeping the system more cost effective. We are now in 2 hospitals in Barcelona performing a study trying to validate this strategy, combining the FIT with the right CRC to improve the efficiency of the system. So thank you very much.
Thank you. It has been, so now we can start the questions and the discussion. So I will start with 2 questions for the 2 of you, and then we can go the one from the public. So which is your lesson learned about this pandemic situation in terms of screening and in terms of symptomatic? And in regards to this lesson, if there is any action plan on the table to manage this lesson learned.
Could you repeat?
Yes. So first, to know the lesson learned that you have you have obtained from this pandemic situation in terms of colorectal cancer screening, and then in terms of this lesson learned, if there is any action plan on the table to face it.
Probably the lesson learned is that we were, due to the pandemic, in a critical situation, but I do think that we managed, with the collaboration of the health authorities and professionals, to manage in the best way possible this situation. Obviously, it was not the ideal situation, but the colorectal cancer screening program, in the use of the FIT, that can allows us to move the threshold of colonoscopies, has helped a lot to manage the situation in the best way possible, taking into account that situation. And I do think that we are the decisions taken sure could be discussed, but I think that was one of the lessons learned, and there is another point, is that we should always improve our screening strategies independent of the COVID situation. And as Dr. Balaguer mentioned, the false positive rate of colonoscopies, of FIT positive colonoscopies, it's a problem that stays in our program. The limitation of colonoscopy resources will probably in our country will last. We will never have all the colonoscopies that we would have, but it probably, and to some extent, probably is not the excess of colonoscopy probably could provoke that we do more colonoscopies than needed. It's so using the wide strategy for the screening and for diagnostic, and that comes from the reduction of false positive, for example, false positive test in our screening program, and we have seen one possible strategy to that, and the thing would be the next steps to consider. At short term, in our screening program, we have to decide if to maintain the higher cutoff or reduce it, taking into account all the factors that I have said. But at medium term, we will have to think how to improve our screening program independent of the COVID situation. Moreover, if one of the challenges, for our screening program is to increase participation. That probably is the best option we have. The best decision or the most we can do to decrease the colorectal impact, to screen all screen all people that have not screened, that have majority of population, and this combination of better screening tests will help us to match these both challenges, probably.
Yeah, I think this is a good lesson learned, no? To be conscious that you can introduce changes, no, in the screening programs, and then to see the impact and how it's going to improve it. Because I think before you were mentioning me that counties there still haven't restart the screening, no, and so it's important that here we decided to restart and making changes and evaluating the impact, no.
That's really true. Some of our programs in other regions of Spain have not restarted the program. The reason is not take a third decision, that is to increase the cutoff, meaning that you will lose 10% of the cancers detection at the round. That does not mean that these cancers the people with this cancer will die. We don't know yet what will happen in 2 years. No, our cancers, not adenomas, so are an advanced stage, but that happens, and we consider that is wise, that it's better to take that decision, explicit decision, than to
keeping the
screening suspended until the things go better.
Okay, thank you. Dr. Balaguer?
Yeah, I think that to me the main lesson learned from this is that so we work in many endoscopy units are open access. That means that the test is ordered usually in primary care or by the other specialists, and we know that in the pre-COVID area the appropriateness of the indication was wrong in 30%, almost up to 30% of the cases. So we were doing inappropriate endoscopies that were competing with appropriate ones. So in the post-COVID area in which we are facing a much burden of endoscopy, we need to first check that the indication is correct, and to prioritize better than we were doing before. So we are now prioritizing the endoscopies indications by high, medium, or low priority. This has been done in many endoscopy units to face the waiting list that we have. And second, the use of FIT test in the symptomatic population is the most objective way of prioritizing, and actually the strategy that has more evidence behind. So I think that the prioritization and the use of FIT in symptomatic patients are the actions that have been taken after the COVID.
That was a question that I already had noted for you. So, and also in this line, if you think that this prioritization is, it will be done from the primary care already, or needs to be done, from there, or it can be kept from the digestive department?
Well, it depends on the system where you are working. I think that the collaboration with the primary care is essential. We need to work with them and what is the right indication. One of the most inappropriate indications of colonoscopy, for example, is surveillance of patients with polyps. That after the screening program, this has been a big burden of our work. That it reaches 20-30% of all colonoscopies that we are doing. So, and there are many inappropriate indications there, mostly because the interval is shorter than the one that is recommended in the guidelines. So definitely you have to work with the primary care, but not only primary care. I mean all the doctors.
Okay, thank you. We will take some questions from the public. So we have for Dr. It can be for the both. I think so. Good add value to include biomarkers to improve the non-invasive detection of colorectal cancer. So they say last week the Spanish Senate voted to include biomarkers in the public catalog of service.
Well, that is an option for the future. You have to take into account that the national the national, the Spanish strategy on cancer, the National Health Service of Spain, it decided, with the collaboration of all participants, it decided what is included in the public services, and now what is included is the screening for the colorectal screening with fit test 40 to 69 days. So any decision to modify this decision should have need to be discussed at the interterritorial committee level and with all the evaluation documents and things needed. But clearly is one of the options. At the beginning it was a chemical test, a WIAC test, and now it's a blood that is physical. But surely it's a way to improve the program in the future, to improve the test, and we'll see.
Okay, thank you. There's another question that says there are difficulties in the primary care introduction fit before ask colonoscopy. Do you have any proposal for the implementation of fit in primary care?
Yeah, so we have implemented the system right after the COVID system, and I have to say that there were no difficulties in terms of access to the test, because this is a widely used test. It's cheap actually, and we haven't found any difficulties in the primary care for doing this test in patients with symptoms. But it's a change in the culture of how colonoscopy has been indicated until now, and it needs many education and keeping track of how the system is working, because it's the difficulty is the change, not maybe the test.
Okay. Here another one. Are there any proposal to reduce the cutoff of fit or age rate from 40 years old, for example, in the screening program for improve the detection of colorectal cancer?
It's an issue, an international issue now, in part because some epidemiological data shows that mainly from America, the States, but not only from there, that the younger people has probably a higher risk than the previous cohorts, than their parents. Mainly, the explanation goes that it's probably associated with obesity problems in that younger generations, and that's one issue. And there are discussions on if we want to expand the age range of the screening program. It would be nice. I do think we have expanded to the younger people or to the older people. In Spain or in Catalonia, our upper limit is 69 years old. Probably, if possible, it would be a positive decision to increase it to 74. These years where the incidence of colorectal cancer is higher than that age, and on the other end to decrease to the younger people. There is a discussion. I do think that that epidemiological situation in America and some other North countries is not happening until now here in Spain. I don't know what's the reason. The risk factors are different here than there. Obesity, it's higher here, but it seems that in America it's high here, but in America, of course, it's higher. Things like that. The consequences of any of those decisions is that we will need a higher number of colonoscopies than we get now. So it has to be a decision taken taking in consideration the benefits and the factibility or the feasibility of doing that.
Yeah, that was my next question. So that will suppose an increase of number of colonoscopies. So which considerations, which is the factor to decide it? Okay. There's another about participation. So participation in a screening program around 42 appears stabilized and low, but do you know what is the percentage of the target population that has participated at least once or twice, but they are not engaged with the 2 years program?
Well, I cannot give that numbers. What we know is that 80-85% of previous participants do repeat screening participation. That's a positive situation. And of the new participants, those who reach 50 years age, less than half of them participate. After that, there are reluctant people, that those that have more than 50 years have invited one time and are invited 2 times, but did not participate in any situation. Probably the strategy would focus on those, not losing the previous participation, not repeating the screening, and focus on the newcomers to the screening to try to reach higher participation. But it seems that once they participate, it's the probability of further participation in the future is higher.
So they are engaged.
And it's what helps to reduce what it produces the benefit of screening, not a single fecal test done, but repeated fecal tests.
Okay, thank you. So I have one question for you, Dr. Balaguer, which is, so in the long term, do you think that the colonoscopy to symptomatic patients, so that they give a negative to this prioritization test, could be avoided in long term? Maybe leaving apart the ones people that they have symptoms of bleeding, but do you think that is an option?
Well, actually, I don't know, in the long term, maybe in the short term, because this last study that I showed you from the UK, that was with patients with high and low risk symptoms of colorectal cancer. You know, the NICE system, they have like 2-week rule in which a patient with high risk symptoms, they should be referred to the specialist to do a colonoscopy in 2 weeks, and they have been overburdened after the COVID, and they cannot fulfill this 2-week rule. And this study was done in high and low risk patients, and with symptoms, high and low risk symptom patients, and the performance was very similar. So if you use a very low cutoff with a very high sensitivity, I think it makes sense to, from a cost-effective point of view and even clinical point of view, to defer or not do that colonoscopy unless the situation changes.
And so, which is the scenario that is required to change this criteria, or?
You know, I mean, in the NICE recommendation, if the fit test is negative, so you don't do colonoscopy.
Okay.
So I think it makes sense. I mean, because otherwise you are just delaying the performance of the test, but the system is burned anyway. So I think that you know, it's with 97% sensitivity. I mean, there are not many tests with such a sensitivity in the market. So I think it makes sense to wait and not do the endoscopy.
Okay. Thank you. So, did the limited colonoscopy availability during the pandemic result on a higher increase of colorectal cancer in later stage? Well, these are things that...
Yeah, I think that we both saw it.
We don't know yet, but it's assumed. The advantage of the screenings is that compared to symptomatic diagnosis, screening data, that is that we detect very early. So probably we'll have some time, then we can delay the diagnostic with with much consequences, what minor consequences. So some limited time, but when past this time, if it's longer than this small time, the consequences could be higher. The modelizations performed based on the for some investigator, based on the delay from positive test or symptoms of positive test to colonoscopy, sometimes shows that we have we have a limited time, that probably the consequences are not very important in volume, but we don't have it, we do not have yet what happens here. Probably in this month we'll have some of the answers on the detection rate and the stages here in Catalonia. But you have to take in mind, or to consider, that the consequences are not, some of the consequences are not, are not on the next year, but on the coming years, 2, 3, 4 years. So the complete impact assessment would need a follow-up and evaluation during the next 4 years, for example.
Okay, I see. So another question that they say, do you plan to make this information, I guess the information of FIT, available in digital health application, La Meva Salut, so users are aware of the situation and can share it with their doctor?
That's what we plan. Yes, we plan. It's one of our important one decision taken some time ago for several reasons is not yet available, and now we send a letter to the participant with the result. But from the point of view of La Meva Salut, the digital personal health history, it's we have worked with them, and the structure of the technical issues are solved, and what we need, and we would like to do it before ending this year, but probably it would not be possible, but at the beginning of this year, that to publish the results of the screening program in the La Meva Salut, and also available to the primary health care doctors, so they can see when attending people for other reasons, they can see if they have participated or not in the screening, and they can make an action to sensibilize, to promote participation in these people. We hope that during the first trimester of 2022 we'll have this publication in the La Meva Salut.
That makes sense. Dr. Balaguer, do you know other strategies in other European or non-European countries for the prioritization in symptomatics? Well, you have mentioned some, no? But
yeah, I think that the most widely used strategy for symptomatic patients is the FIT strategy, but with the COVID, as I said before, with the COVID situation, there's been many societies that have designed like prioritization indications for endoscopy, upper and lower endoscopy, and I think that this is probably the most widely used. I mean, the clinical evaluation of the indication and the FIT test.
FIT test.
Yeah.
Okay. Even European or non-European.
Yeah, I think so. Yeah.
It's the same line
Yeah.
now. Okay. And then the same question also for the. Oh, there's no. No more question. No. No, it's the same. Okay. So in the same way as for you in the screening, in terms of a screening, so there's other strategies in Europe different that has been taken in here to restart the screening in the pandemic.
In Europe, there are two main strategies for screening, those based on faecal immunochemical tests, the majority of Europe, but some countries like Germany and other countries, Poland, I do think, they screen directly with colonoscopy. That's one thing. I do think the most, focusing on the fit screening test, I do not know of other strategies to restart the screening test different than that. They are discussing what I mentioned, that what are the things you have to take into account. Restart as soon as possible. Well, we do not need modeling studies to say that. For sure, it's the catch up, the work not done, but or to maintain the participation, and all the things are moving in that way. Probably the most crucial decision is to move the cutoff point, compared to not to move it and to keep inviting people, with the consequences that if the capacity of a colonoscopy is not enough, the length of the round, individual round will be longer as the months passes. But they are discussing these decisions and the impact of differences in these decisions. But as far as I know, there are no other strategies on the table or applied on other screening programs.
Okay. And then was just one last question in terms of the screening, because the participation, as before they mentioned also, that is low. So in other counties here in Spain, they have a higher rate of participation. Do you know which is the cause of this difference? Of there's a different strategy, but why they are having higher rates of participation in the screening programs?
We have some elements that you can think that are important. One, sure, one of the regions with a higher participation rate is the Basque Country in Spain, but it has also a higher participation rate in breast cancer. So it's not what we do, what you do, or what you do in both screenings. That's one thing. But for example, in the Basque Country, they send, as far as I know, they send the fit kit to the home. So the studies done internationally show that's one way to increase the participation rate. The negative part of sending the kit at home is if our participation is very low, these kits are lost. At the economical and things like that. But that is one thing that could mark the difference in participation rate, and we are now thinking how can we apply this knowledge here in our screening program. Send the kit to the first time invitees, it could be a measure.
Okay.
And after that, there are socioeconomical differences. In Catalonia, we have regions with higher than 60% participation rate, and others, most of them in the metropolitan area of Barcelona, that the participation is very low. So there is a socioeconomic or demographic, socioeconomic factor that influences the participation, which is not new in the screening preventive measures. But there are a common number of factors, that do know that participates that influences the participation. Some of them are modified, the others are not. We have to see strategies to minimize the impact of these not modifier factors in participation.
Okay, thank you. So I think time is up, and we can stay longer, but there is no more time. So thank you for sharing your experience and giving your insight. I think we all have enjoyed this panel. I just want to close the session just with the main home message, that I think that all of us we have to get, that that we can only face COVID-19 impact on colorectal cancer screening and symptomatic prioritizations with the optimization of colonoscopies, that is sure. And so in this line, I think it's of utmost importance to bet for the innovative solutions for this, I think. So I think let's start work on this. So thank you.
Thank you.